Hello and welcome to the topic Neuropathic Ulcer in the Dermatology module. By the end of this topic, you should be able to define neuropathic ulcer, explain the pathophysiology of this ulcer, outline the causes and classification of neuropathic ulcers, describe the clinical manifestations, outline the investigations, discuss the principles of management, and discuss the complications and prognosis of a neuropathic ulcer. Let's get started. So an ulcer is practically a break in the skin or mucous membrane with loss of surface tissue, disintegration and necrosis of epithelial tissue. And neuropathic ulcers occur as a result of peripheral neuropathy and is typically seen in diabetic patients. Let's take a look at the root and cause of the nerves for the lower limbs. The sensory nerve is responsible for sensation such as temperature or pain. The nerve innervation of lower limbs mainly by two major nerves, which is the sciatic nerve that supplies the posterior part and the femoral nerve that supplies the anterior part of the lower limbs. Lumbar plexus is formed by the ventral rami of L1 to L4, and it forms the lateral femoral cutaneous nerve which innervates the lateral thigh, the femoral nerve that innervates the anteromedial thigh and the anteromedial lower leg. The medial ankle and foot are supplied by saphenous nerve, and obturator nerve innervates the distal third of the medial thigh. The lumbosacral plexus forms the sciatic nerve. The posterior cutaneous nerve of the thigh provides sensory innervation to the inferior buttocks and the posterior thigh. Sciatic nerve gave rise to the common fibular nerve, also known as the common peroneal nerve and tibial nerve. The common fibular nerve provides sensory innervation to the posterior lateral lower leg and the dorsum of the foot. The common fibular nerve branches into the deep fibula and superficial fibular nerves. The superficial fibula provides sensation to the dorsum of the foot except for the region between the first and the second digits, which are provided by the deep fibular nerve. The tibial nerve provides sensory innervation to the heel and sole of the foot. The sural nerve, which is S1 to S2, provides the sensation of the posterior lateral lower leg, including the lateral margin of the foot to the fifth digit. Motor nerves are responsible for contraction of muscles. The deep fibular nerve that originates from L4 to S1 innervates muscles in the anterior compartment of the leg and some intrinsic muscles of the foot. Superficial fibular nerve innervates muscles in the lateral compartment of the leg. Muscles in the posterior compartment of the leg and majority of the intrinsic foot muscles are innervated by the tibial nerve. Diabetes mellitus is the main cause of neuropathic ulcer, and that's why we will be discussing the pathophysiology of the ulcer caused by diabetes in this slide. Diabetes mellitus causes activation of few pathways, namely polyol pathway, hexosamine pathway, advanced glycation end product precursors, and diacylglycerol pathway. The polyol pathway may cause increased sorbitol and increased fructose formation. Hexosamine pathway causes increased glucosamine. Advanced glycation end product precursors are glyoxal and methylglyoxal. Diacylglycerol pathway causes increased protein kinase C activation, and these pathways eventually lead to increased oxidative stress, pro-inflammatory gene expression, altered protein function, endothelial damages and platelet activation, and all these result in neuropathy. Neuropathy causes limited joint mobility and subsequently foot deformities. Neuropathy also can lead to loss of protective sensation, hence increased risk for shear pressure and injury, which will lead to a foot ulcer. Now these are the common causes of neuropathic ulcers. Can be secondary to poorly controlled diabetes leading to peripheral neuropathy, renal failure, secondary to trauma, and it could also be secondary to surgery. So neuropathic ulcers are generally classified based on the Wagner's classification. This table here shows the classification. Grade 0 indicates no open lesions but may have deformities or cellulitis. Superficial ulcers, either partial or full thickness, will be graded as grade 1. Grade 2 refers to ulcer extension to the ligament, tendon, joint capsule, or deep fascia without abscess or osteomyelitis. Any deep ulcer with infections such as abscess, osteomyelitis, or joint sepsis is classified as grade 3. Grade 4 is for gangrene localized to the portion of the forefoot or heel and grade 5 indicates extensive gangrenous involvement of the entire foot. Let's discuss the clinical manifestation of neuropathic ulcer. When taking a history from the patient, symptoms of diabetes mellitus such as polyuria, polydipsia and polyphagia should be included. Symptoms of peripheral neuropathy such as hypoesthesia, hyperesthesia, paresthesia and dysesthesia, radicular pain or anhidrosis may be presented by the patient. The patient may also come in with skin changes and painless ulcers. If the ulcer is infected, fever might be a presenting symptom as well. So when we are examining the ulcer, we should note that it's a well-defined punched-out lesion. The surrounding skin will be callous. There will be undermining that might be noticed in the wound. The ulcer is usually painless unless it's infected. It is located around bony prominences and weight-bearing surfaces such as the dorsal interphalangeal joints of the hematose and the distal tips of the digits, below the metatarsal heads in the claw toes, the medial and lateral forefoot in patients with bunions, plantar lateral wounds in Charcot foot, and lateral foot as well as the lateral malleoli in various deformities. Gross deformities of lower limb may be noted and there might be limited range of motion at the ankle, interphalangeal joints, metatarsophalangeal joints, mid-tarsal joints and subtalar joints. The patient may also have reduced muscle power of dorsiflexus, plantar flexus, inverters and everters. The surrounding skin also may be dry and callous. Physicians should also look out for systemic signs such as insulin resistance, for example, acanthosis nigricans, skin tags and obesity. So as shown in this lesion picture, it's a well-defined punch-out painless ulcer at the pressure point, and this is pathognomonic for neuropathic ulcer. The most important tests which can be done early would be blood sugar screening. Random blood glucose, fasting blood glucose and HbA1c can be ordered to detect any underlying risk factors, which is namely diabetes, and to look at the adequacy of glycemic control. Other lab investigations which can be carried out to assess the complications of diabetes include renal function tests, albumin levels, which are generally associated with poorer prognosis if the levels are low, a full blood count, which can look at presence of leukocytosis, and this could be associated with diabetic foot infection, anemia, erythrocyte sedimentation rate and C-reactive protein increment could indicate inflammatory markers being positive for infection or presence of osteomyelitis. As for imaging studies, weight-bearing clean radiographs of the foot in 3 views are helpful to look at deformities or osteomyelitic changes or soft tissue gas changes, presence of soft tissue gas within the compartments of the limb. MRI also can be performed to detect osteomyelitis, deep space infections, infectious tenosynovitis, myositis, and septic arthritis. CT scan is another imaging investigation that can detect osseous changes such as cortical erosions, pathological fractures, and periosteal reactions. Bone biopsy is the gold standard for confirming the diagnosis, and osseous specimens are sent for histologic and microbiologic evaluation. Skin biopsy is done for non-healing chronic wound, and this is done to rule out malignancy, also known as Marjolin's ulcer. To monitor the progress of a neuropathic ulcer, especially when there's infection, erythrocyte sedimentation rate and C-reactive proteins are sent to determine the efficacy of treatment. Serial X-rays can be done for Charcot arthropathy. We may also notice obliteration of the joint space and fragmentation of both articular surfaces of the joint that leads to subluxation or dislocation, scattered chunks of bones in the fibrous tissue, surrounding soft tissue edema, joint distension by fluid, and heterotropic ossification. Now let's look at the management of neuropathic ulcers. First of all, this would involve offloading. So non-removable casting should be offered for plantar neuropathic and non-ischemic uninfected forefoot or midfoot neuropathic ulcers. It can be the management for Charcot's arthropathy too. Next, control the foot infection with antibiotics if they are infected. Wound debridement and wound dressings are also important management of the ulcers if they are extensive. Long-term management of underlying risk factors such as diabetes and joint deformity should be considered. Antibiotics is only indicated if the ulcer is infected. The first choice of antibiotics would be oral flucloxacillin. Alternative first-choice antibiotics for patients with penicillin allergy would be doxycycline or clarithromycin or erythromycin for pregnant women. Second-line oral antibiotics include coamoxiclave or cotrimoxazole, and if patients are severely unwell, intravenous flucloxacillin with or without gentamicin and metronidazole can be considered. Coamoxiclave with or without gentamicin, or cotrimoxazole with or without gentamicin, or metronidazole are the other alternative first-line intravenous antibiotics. Second choice antibiotics for severely unwell patients would include piperacillin and tazobactam or ceftriaxone with or without metronidazole. And if methicillin-resistant Staphylococcus aureus infection or MRSA is suspected or confirmed, vancomycin can be added to the regimen. Surgical procedures such as debridement can be done with negative pressure wound therapy. Negative pressure wound therapy is a method of drawing out the fluid and infection from a wound to help it heal. Bandage is sealed over the wound and vacuum pump is attached. The complications of neuropathic ulcer include infection, which puts the patient at risk of sepsis, gangrene of the foot, osteomyelitis, and permanent deformity. Neuropathic ulcers have high risk of amputation and high recurrence if not managed well. The good prognostic factors include early treatment and early staging of the ulcers, while infected ulcer and delayed treatment may carry poorer prognosis. So let's summarize what we have covered so far. Neuropathic ulcer is a break in the skin or mucous membrane with loss of surface tissue due to peripheral neuropathy. Diabetes is one of the major causes of peripheral neuropathy, which eventually leads to neuropathic ulcer. Clinical manifestations of neuropathic ulcers include painless, well-defined punched-out ulcer at the bony prominences and weight-bearing surfaces. Investigations of neuropathic ulcer include blood glucose profiling and weight-bearing plain radiograph to detect the foot deformity. The mainstay of treatment include offloading, controlling of the foot infection, wound debridement, and dressing as part of source control. We have come to the end of this topic. Thank you.